Good morning, everyone. The topic of my report today is match analysis of tumor recurrence patterns after hepatectomy with very narrow resection margins for HCC. The literatures of the past for HCC hepatectomy about how wide surgical margins should cut are controversial. Data in Queen Mary Hospital, Hong Kong, using 1 centimeter as a cutoff point to compare outcomes between greater than 1 centimeter and less than 1 centimeter margin group. They had similar recurrence rates and survival. Another data in Jutendo University, Japan, comparing microscopy surgical no margin method versus microscopy margin hepatectomy group. They had similar disease-free survival and overall survival. Only positive margin accounts for 12% influence disease-free survival. As data in Chang'an Memorial Hospital, our own pooling data tell us resection margin wider than 5 centimeters have improved disease-free survival. For alpha fetoprotein greater than 200 preoperatively, greater than 1 centimeter resection margin is recommended. The only prospective randomized trial that single-blinded stratified patients according to their surgical margins, 1 or 2 centimeters, advocated that wider margin gave a survival advantage only to the patients with HCC less than 2 centimeters. However, the margin width did not show any significant impact or help on tumor recurrence, regardless of HCC size. In France, one intention to treat analysis, hepatectomy with narrow margin less than 1 centimeter or R1 resection did not impair the transplantability of recurrence and influence patient survival. Meta-analysis in China, including 14 studies aiming cutoff surgical margin at 1 centimeter, associate improved and favorable outcomes, including 5-year DFS and OS with wider surgical margin group. However, data of these studies are retrospectively collected. Following are two representative cases. In the first one, the tumor lies on right portal vein. The second one, tumor is close to middle hepatic vein. After resection, right portal vein exposed. After it was detached from the vessels. Both specimens are solitary HCC. Therefore, we assume its close resection margin less than 1 millimeter from pathologic examination inevitably associated with worse clinical outcomes. Figure 1. Flowchart of the study population. We retrospectively collected 1,116 patients HCC diagnosis from April 2003 to December 2009 to allow 5 to 10 years adequate long-term follow-up duration. Exclusion criteria are in-hospital mortality, margin involved, mixed-type HCC, and fibrolaminar HCC. Per protocol, we had 983 patients. After PSM, propensity score matching, there are 173 patients in each arm, which is adequate sample size by power calculations. Primary endpoint is tumor recurrence rate. Secondary endpoints are prognostic factors related to close resection margin and tumor recurrence patterns. We use 18 covariates for propensity score matching, of which 8 are patient factors, 2 are surgical factors, the other 8 are pathological factors. Matching algorithm is nearest a neighbor ratio 1 to 1, maximum allowable difference less than 0.05. Other biostatistical methods are listed in this slide. Table 1, either before or after PSM, the two groups did not show any difference in the preoperative patient factors. The median age of our patients was 58 years old. 79.3% were male and 63.1% displayed HBV infection. Among the patients, most of them are childhood A classification. Regarding the surgical and tumor factors, the close margin group displays significantly greater intraoperative blood loss and tumor sizes. However, blood loss and tumor sizes were comparable between the two groups after adjusting for propensity scores. Table 2, when we analyze the risk factors associated with close margin resections, the univariate multivariate analysis showed that a tumor size greater than 5 centimeters was the only independent prognostic factor. Totally, we included 983 patients in the analysis. The median follow-up duration was 85 months. Regarding the distribution of Tiananmen staging, most of our patients were in stage 1B, accounts for 49.4%. Figure 2, 710 patients are in the wide margin group. 273 patients are in the closed margin group, respectively. Before PSM, the recurrence rates were significantly higher in the closed margin group than in the wider margin group. The median 5-year recurrence rates were 63.7% versus 54.7% in the closed margin and wider margin group, respectively. Following propensity score matching, the recurrence rate were not statistically different between the two groups. Table 3 univariate multivariate analysis for factors associated with tumor recurrence. By multivariate analysis, we observed that a low platelet count and the presence of tumor microvascular invasion were the only significant factors for tumor recurrence. So far, our study found the tumor recurrence rates are not significant associated with resection margin width, either wide or narrow. Interestingly, it was the patient pre-underlying characteristics that matters, such as thrombocytopenia, indicating the degree of liver cirrhosis and portal hypertension. More importantly, the tumor biology, such as microvascular invasion, outscores surgical margin as a significant independent risk factor for tumor recurrence, which means tumor microenvironment seems to be the decisive factor of tumor recurrence. Figure 3, patterns of tumor recurrence and patient survival. The patterns of tumor recurrence were not significantly different between the closed margin and wider margin group. When we further evaluate the impact of closed resection margin on section margin recurrence or early recurrence less than 1 year, we also did not find any significant difference between the two groups. After PSM matching, we concluded the patients with very narrow surgical margins show outcomes comparable to those with wider margins. Most recurrences were multiple intrahepatic recurrence related to the degree of portal hypertension and adverse tumor biology. While all conditions are suitable and possible, a wide tumor-free margin is paramount during oncological resections to avoid residual tumors at the resection site to promote tumor recurrence. However, while the tumors close to major hepatic veins or branches of the Gleason pedicles are detached from the vessels with QSA and a sufficient surgical margin is sacrificed to preserve more liver parenchyma, with special concern, a very narrow tumor-free margin resection still represents an effective therapeutic strategy. It is the end of my speech. Thanks for your attention.